We have a recommendation to treat elderly patients with colorectal cancer with either monotherapy of 5-FU if they have some frailty, or in fit patient or patient with very symptomatic disease, we give them the doublet chemotherapy. So it was 5-FU plus oxaliplatin or irinotecan. About Bevacizumab, we have just one randomized trial that have demonstrate significant improvement of progression-free survival in elderly patients over 70. But we have some concern about the tolerance and the maintain of autonomy and quality of life in these patients with Bevacizumab. That's why SIOG recommends new trials assessing not only traditional oncologic endpoint as overall survival or progression-free survival, but also quality of life and maintain of autonomy. Of course, in our trial and in the literature, we assess all the type of toxicities. We did not find an excess of hematological toxicity in our trial with Bevacizumab. Not so digestive toxicity, but cardiovascular toxicity, but it is consistent with previous trial that found that there is more thromboembolic events and hypertension, but this remain manageable. Our trial was specific for patients over 70. And we did not made a substratification in our recruitments. In the literature, there is some data that demonstrate that after 80 or 85, so the prognosis could be worse and the chemotherapy less well tolerated. And it's one thing I think it's clearly demonstrated that patients over 60 or 65 did not have a frailty that have to give a specific treatment. I mean, between 65 and 75, we can treat patient as a younger patient in the metastatic colorectal cancer. Our trial was about Bevacizumab in metastatic setting, and in non-metastatic setting, Bevacizumab was explored by two large international randomized trials, not for elderly but for every patient. And unfortunately, it was clearly demonstrated that Bevacizumab had no added value in the non-metastatic. Yeah, I think that's our trial was a phase 2 randomized trial, so our effective was only of 102 patients, so we cannot draw a large conclusion. But we found that according our criteria, Bevacizumab was efficient and safe. And an interesting finding from a subgroup analysis show that the Bevacizumab benefits is maintained in patients with some frailty criteria, as denutrition or impaired autonomy. So that means that, and I think that's an important finding of this study, that we should not exclude or delay treatment with Bevacizumab in patients with some frail characteristic. Why in these patients probably we don't have a second chance. They probably have less second-line chemotherapy. So if we want to use the best treatment option, it should be used at the first line, at the beginning of the treatment. Recommendation. We perform a median time to autonomy or quality of life degradation, and we did not observe worst autonomy or worst quality of life under bevacizumab. So for this criteria, bevacizumab could be considered as safe. And this is the added value of this trial to the previous trial that have already demonstrated that bevacizumab prolonged progression-free survival.